So in this video, we'll be covering the basics of muscle inhibition, and specifically as it relates to mechanical causes, including joint dysfunction. I hope to provide some evidence-based background and context of muscle inhibition and show you why this is an important phenomenon that every manual provider who treats musculoskeletal injuries should know about. So the simplest definition of muscle inhibition is that it represents an alteration of the efferent signal from the spinal cord to the muscle. We'll only be talking about biomechanical causes for this. Obviously, there are other reasons, for instance, primary neurological conditions such as MS, but we'll limit ourselves to the mechanical reasons. There are different mechanical reasons why this happens, but the net effect is the same. It's distortion of that efferent signal. So we're going to start by building the case as to why muscle inhibition matters so much. The first thing to understand that really explains a lot is that inhibited muscles just don't activate normally. So muscle activation is a measure of the electrical impulse coming into the muscle as measured by EMG. This is some raw data from a pilot subject, a study that we're currently working on. And as you can see, the discrepancy between the unaffected side with the red line and the inhibited or affected side. It's just not activating fully. If this side were just weak, these lines would be much closer. Maybe one side couldn't put out as much force, but the activation would be much closer. But the inhibited side just isn't getting the signal. Consequently, it can't contract fully, and consequently, it's weak. So one consequence of this reduced activation is that inhibited muscles just don't respond appropriately to treatment or rehab efforts like they should. If you've ever had a patient tell you, Doc, I'm doing my clamshells, but my bad hip, it just doesn't seem to want to engage, there's a good chance there's inhibition present. Now, that doesn't mean the muscle won't respond at all. If you're working both sides, but one side is inhibited, you'll start off with a discrepancy, and the affected side will make strength gains, but it will continue to lag the unaffected side. This is obviously frustrating for both the patient and the provider, and is one cause of treatment failure to otherwise sound treatment plans. In fact, I find muscle inhibition to be a frequent underlying factor in many different types of musculoskeletal injury, particularly your quote-unquote overuse injuries. The key word there is underlying. It's there, but you have to look for it. Muscle inhibition creates some of the same effects as weakness, most notably joint destabilization and muscular compensation in the form of synergistic dominance. So, with our runner here with a positive Trendelenburg, it's pretty obvious these right-sided glutes aren't firing fully. So this is going to create stress in the SI joint, the lumbar spine. Muscularly, it's going to create stress in the paraspinals and QL, the other smaller glutes, hamstring, quad. As you know, the body doesn't think in terms of muscle, it thinks in terms of movement. So it's going to pull in whatever other muscles it needs to get the job done to keep moving forward. Normally you treat this with core and glute strength, but what if she's already doing that and it's just not responding like it should? Unfortunately, despite all the trouble that muscle inhibition causes, I believe it's still highly under-recognized, underappreciated. I've treated hundreds of athletes like the woman in the previous slide who are feeling the effects of inhibition, despite efforts to the contrary. When I explain what's going on, one of the most common things I hear is, well, that makes complete sense. How come no one's ever explained it to me like that? The evidence is out there. Over the years, I've accumulated a slew of studies relating to muscle inhibition, going all the way back to 1994 up through present day. We'll get into specific studies in a moment, but this is just an example of a dozen or so that document the existence of muscle inhibition. So next we'll start talking about the scenarios by which muscle inhibition happens. And again, we're going to limit our discussion to the mechanical sources. There's three main versions. The first would be altered reciprocal inhibition. The second would be nerve root irritation, like that which happens from subluxation. And the third is called arthrogenic, arthro meaning joint, so arising from the joint muscle inhibition happening locally from a joint effect. So one scenario that muscle inhibition happens is in response to an excessively tight antagonist. As in the case of lower cross syndrome, if the hip flexors, for instance, are excessively tight, it can inhibit the glutes from firing. Reciprocal inhibition is a normal reflex, as we know. For one muscle to contract, its antagonist has to relax. But if a muscle is excessively tight, it crosses the line into altered reciprocal inhibition, which might require manual release to resolve. A famous example of altered efferent signaling would be the subluxation. I guess famous if you're a chiropractor at least. Something that's been ingrained in our brains since day one. So via nerve root irritation, you get downstream effects, including muscle weakness. So in this case, we're primarily talking about the C-spine, lumbar spine, and sacrum. In case you're wondering, there is pretty good evidence to support adjusting the C-spine and lumbar spine to help motor function. At least a dozen studies to this effect. A summary of these studies shows the usual suspects: adjusting the lumbar spine to affect the quads and the hamstrings, adjusting the C-spine to address biceps, grip strength, and shoulder. I think these studies are intuitive to most chiropractors, and it's good to know that the evidence supports it as well. And so now we come to the third category of muscle inhibition, and that's relating to the local motor effect to joint dysfunction or subluxation. Again, the best term for that is arthrogenic muscle inhibition. So for instance, the lower traps could be inhibited by an issue at the cranial nerve 11. The lat muscle could be affected by its innervation at the lower C-spine, but they both could be affected by subluxation at their lower thoracic spine where they both attach. This is a type of inhibition I think most often gets overlooked. The principle is fairly intuitive. I think most people would agree with Liebler's statement here, but it's not something that I find people are really looking for. And this is where we're going to spend the majority of our discussion talking about, and something that I've spent the past 20 years researching, and I hope to share with you what I've learned. So I used muscle testing for many years prior to getting into the research. I noticed there were many occasions where I was influencing muscle strength in ways that were not reciprocal related, or not innervation level related, but more locally. When I did look into the research, I learned that this phenomenon has been described: arthrogenic muscle inhibition, local. I'll let you read the formal definition. The gist of AMI is that a joint issue is affecting the afferent signal to the spinal cord, and this is the source of the efferent signal alteration. So the mechanism of AMI goes along the lines of this. You have a joint injury, effusion, swelling, or even an induced infusion, stimulates the joint mechanoreceptors, increases afferent discharge to the spinal cord, excites an inhibitory interneuron, which inhibits the alpha motor neuron, which prevents full muscle activation and contraction. There's some different theories about what's exactly happening at the spinal cord level, but those are the basics. You can actually measure or quantify AMI with something called the H/M ratio, which basically represents the total number of motor neurons capable of firing versus the total number of motor neurons that are actually firing. And the rest of these are inhibited. And we'll show some examples about this later. While most of the action is happening at the spinal cord level, there is some recent evidence of cortical involvement. If the joint issue has been happening long enough, you get changes in the motor cortex as measured by functional MRI. The phenomenon of AMI has been around long enough and has enough evidence behind it that, to paraphrase this researcher, it's a thing and it can occur pretty much anywhere. Interestingly, it's not talked about much in chiropractic circles, although I hope to show why it should be. AMI was first discovered and is best well known in the quads relative to the knee joint injury, effusion, infusion, osteoarthritis. I'd say at least 3/4 of the research out there relates to the knee and the quads. An example would be this particular study, where they confirmed the role of the joint afferents by aspirating effused knees, which stopped the AMI, or injected a local anesthetic into a knee and then infused it, and it prevented the AMI. In this study, they took patients who were already having a hip arthrogram procedure, and they measured glute max activation levels pre and post dye injection into the hip joint. And interestingly, even before the injection, you notice the affected side, assuming there was a problem with the hip joint, already had a 10-point deficit in activation. In the control group, there was no change, but after the injection into the hip joint, they lost another 30 points plus. Some of you might recognize the name on this, one of the authors of this study, Stuart McGill. We talked earlier about the H to M ratio, which is a measurement of inhibition. In this study, a couple of studies, they've looked at patients with functional ankle instability, which is characterized by episodes of giving out or locking up in patients post-ankle injury. And they discovered in these patients they had depressed H to M ratios, which indicates AMI. It's important to note that joint issues don't solely inhibit muscles, they more alter muscle firing, much in the same way as global warming is better described as climate change. You get alterations in the way muscles function, including facilitation. So while some muscles get turned down, others get turned up. Even the same muscle can go either direction. The soleus and peroneals that we just talked about in the last slide in other situations can be facilitated in response to ankle effusion. And the glute medius, which is known to often suffer inhibition in patients with ankle issues in the fifth study here, in other situations can be facilitated in certain phases of gait. The fourth study is interesting. It shows that glute max and the peroneals again can be facilitated, and the authors speculated that this was a feed-forward mechanism. The brain was prepping the muscle in anticipation of a functional exercise, knowing that other muscles were inhibited to make up the difference. As far as evidence-based treatment of AMI, unfortunately, despite the fact that AMI can pretty much occur anywhere, any joint, any muscle, virtually all of the studies in the literature focus on quadriceps AMI relative to the knee joint. Looking at a recent review study of the treatments postulated to possibly help, cryotherapy of the joint was the only one that really seemed to make much difference. Electrical stim, despite the fact that you can work around the inhibited motor neuron pool, doesn't address the underlying inhibition itself and had little effect. Ultrasound vibration, taping, bracing, heat, soft tissue release, very little effect. We touched on a moment ago the changes in the motor cortex, but even a modality that stimulates the motor cortex directly, transcranial magnetic stimulation, had little effect. To me, this all speaks to the fact that the root of the problem is really at the joint level. This is a schematic from that review study showing the pathways or mechanisms by which some of these modalities could theoretically work. And again, if you'll notice, the cryotherapy is the only one that really addresses the joint. Now, there is a modality that is known to address most of these pathways, known to stimulate afferents, specifically mechanoreceptors, help with sensory processing, muscle activation, even affect things at the cortical level. So I'll give you a pop quiz here. What is this modality? And I'll give you a hint. If you're a chiropractor, you get 3 guesses, but the first 2 don't count. Hopefully you guessed the answer. Adjusting, of course. It's known to do all of these things and more. It would make sense if the problem is at the joint level, then in some situations, some circumstances, joint manipulation could help. So in addition to curing Harvey's deafness here, DD could also be helping his trap inhibition, which is happening as a result of T-spine subluxation. And all kidding aside, there is a study that shows that, and we'll talk about in a minute. And if it helps, there's a growing body of evidence that supports the use of manipulation as a valid tool in treating muscle inhibition. In performing a literature review going back to 2000, I pulled out 18 studies showing positive motor effect from manipulation. And I put these into 2 categories, and there's a roughly even split between the 2. The first category is what we discussed earlier, manipulation directed at a muscle's innervation level. So for instance, adjusting C5 to help the bicep. But the second category, which I believe speaks more to the local AMI phenomenon, are a category of studies that show manipulation at or near the muscle's attachment. Going back again to at least 2000, I pulled up at least 9 studies showing a positive local motor effect to manipulation. The last one is our study, which I'll touch on in a moment. In summarizing these studies, we have 2 showing lower trap strength improvement after manipulation to its origin in the lower T-spine, 2 showing glute max strength improvement after hip joint manipulation, 2 relating to the hip abductors, one with the hip joint, the other with the ankle, and the quads, this time with the SI joint, not the knee, and the soleus relative to the ankle. So I'll give you 2 quick examples. In one study from Cleland et al. In 2004, they took healthy subjects, did a supine thoracic manipulation, high velocity, and improved lower trap strength by 14%. Another example is this study from 2019 in subjects with a musculoskeletal knee injury, so meaning not an internal structure such as ACL or meniscus, but more like a patellofemoral condition. So in these type of subjects with a greater than 10% difference in strength between their legs, a single hip distraction adjustment increased glute max strength by 15%, although it did not change glute med or quads. And finally, in our group study, we were able to show an interesting finding. Up until now, we've discussed the local muscle effects of manipulation, but in this case, we were able to show a proximal hip effect, hip abductor strength and activation improving from a distal intervention, an ankle manipulation. So in subjects with a prior history of ankle sprain and demonstrated hip abductor weakness unilaterally, 1 session of ankle joint complex manipulation increased activation, bringing the deficit up to normal, and also force production, again bringing the deficit up to normal. This study will be covered in its own presentation. Something that I came across in my literature review that I find very interesting is looking at the magnitude of the effect, or the size of the benefit of the motor effect. And looking at the second category of studies, the 8 studies that covered most pertain to AMI, 5 of these studies had results that were all clustered in a very tight window, ranging from 14, 15, 17, 18%, pretty small margin. It would appear that we're on our way to quantifying the degree of the inhibition. We're currently piloting another study looking at the hip adductors, going through several itinerations of how to best measure that force, and we start seeing that 14 to 15% result. We know we're on the right track. So this leads to an important point. In my opinion, there's a disconnect in the literature between the fact that AMI is a known phenomenon, arthrogenic muscle inhibition is a known phenomenon, and the fact that a treatment that affects the arthro, the joint, could help. I believe this disconnect is mainly due to the fact that most AMI studies focus on the quads relative to the knee. And admittedly, if you have an effused knee, manipulation is probably not the treatment of choice for that, but in other circumstances, works quite well. My observation is that subluxation-induced AMI occurs significantly more frequently than is recognized or talked about. Again, we're not talking about the innervation-related muscle inhibition that happens in the lumbar and cervical spine, but more the local effects from subluxation. The easiest means of identifying AMI is with muscle testing. A lot of people have a bad association with muscle testing, which is unfortunate because it's really kind of hard to identify otherwise. Consequently, if you're not muscle testing, you're likely missing out on this important phenomenon in your patient's injuries. There are really 2 sides to the coin with muscle testing. You can use it in 2 different ways, at least. Diagnostically, if you understand the consequences associated with muscle inhibition, you can predict patterns of musculoskeletal injury. So for example, if you have a runner with anterior hip pain, or just as likely an anterior knee pain, and if you recognize that their effective size psoas is inhibited, it'll fill in the clinical picture as to why perhaps their iliacus and rectus femoris are tight. Again, synergistic dominance compensating for the inhibition. This is very helpful in the treatment of those conditions. The other side to this coin is in using muscle testing as a screening tool to quickly evaluate the joint integrity of a given region. So in our psoas example, the fact that psoas is testing weak indicates a subluxation somewhere along its attachment, anywhere from L4 up to T12. It could also be at the hip joint, but it tends to be more in the lumbar spine. Another piece of information you can gather from the psoas being inhibited is that there's likely a soft tissue deficit creating or allowing for the subluxation to exist. So for example, perhaps your patient doesn't possess adequate core strength, specifically transverse abdominis. Or perhaps it's a mobility issue and they've suffered a past trauma and have adhesions in the QL muscle that are pulling on the spine. The human body is a pretty complicated machine, but from one simple muscle test you can obtain a lot of information to get you pointed in the right direction at least. These two aspects of muscle testing form the backbone of a unique set of protocols that we've established in our offices to help us successfully navigate the complexities of the musculoskeletal injuries that we specialize in treating. I'm working to develop a platform from which to start sharing this information with other providers. We'll be adding more content as time goes on, so keep checking back and let me know your thoughts and questions. The final wrap-up thought from this discussion is that you're doing more with your adjusting than you might realize. You're also frequently addressing muscle inhibition and its consequences. However, unless you muscle test, you're also missing a lot of muscle inhibition and its consequences. Thanks for listening and have a great day.